was thinking about the next webinar, and I really thought, who am I going to invite to join? And it just became very clear to me to reach out to Craig and for him to share his sort of knowledge and experience. And I mean, he really doesn't need much of an introduction in terms of podiatric medicine. Most of us have heard of Craig Payne over the years from his work in La Trobe in the university, and also what he's done in the podiatry arena, and also what he's done with Ian Griffiths in Pod Chat Live. So, I mean, I'm absolutely delighted to have Craig come along, and specifically to speak about orthotic dosing. And in the context, if you think about it in terms of the pharmaceutical industry and how they give medications based on therapeutic doses. And I know I've had many a conversation with Ian along the ways as to, you know, how do we create a prescription that gives us the most effective results and the best outcomes. And of course, that brings me back to conversations that Ian Griffiths has had with Simon Spooner, and he would be a great mentor for Ian. And he talked about creating prescriptions that would put people into this zone of optimal stress. And that was really looking at the loading of structures and what would tip the kind of the condition into like pain or injury. And, you know, some people would put a 3-degree varus post on, some people put a 5-degree varus post in, and yet these podiatrists were telling us we're all getting great results. So maybe it's not so much the specific dose as to that zone of optimal stress, but of course you're going to share your concepts on that with us, Craig. So I think maybe if we kick off with just, if you could give us a little intro into yourself, Craig, and then if you could go straight into your PowerPoint, and at the end we'll take questions.
Sure, great. Thanks for that introduction. I will just share my screen to get the ball rolling. But as kind of said, my background is, even though I'm in Melbourne, Australia now, I started off in Christchurch in New Zealand a very, very long time ago. I moved across to Australia to take up a teaching and research post at La Trobe University and spent a long time there teaching this stuff and struggling with the teaching of the stuff. Because it's not as clear cut as we would like. And I'm going to delve into some of those issues. That led me to start running some of the clinical biomechanics boot camps that I did, the 2-day course that I ran all over the place. And that I learned a lot through doing that. Since then, we've now evolved into Pod Chat Live and get a lot of good guests on that further challenge your thinking and add more concepts. I also do write several blogs and obviously teach a course online on clinical biomechanics and critical thinking. And it's the application of that critical thinking that we really need to help understand, say, foot orthotic prescribing and what we're doing clinically. It's also obviously very well illustrated in what's going on around the world now. You know, some of the issues. Well, by the way, this is the headline in this morning's newspaper here in Melbourne. We're in week 2 of a hard lockdown, and we only had 22 new cases yesterday. A week ago, we had none for a few weeks. So we have actually, in the last 18 months, had spent 6 months of that in hard lockdown. So Australia tries to get it to 0 and keep it at 0. We have had the number of cases in the UK on a daily basis is how many we've had in total. So you can see very, very different approaches. My point of really putting this up was, I'm sure you're all familiar with the conspiracy theories going on, the pseudoscience going on, the nonsense that goes on around COVID. So those critical thinking skills are probably more important than they have ever been. So to move into it, effectively, foot orthotic prescribing for clinical practice, for teaching, for whatever, is allegedly driven by theory, evidence, and science. But in reality, it's actually driven by conflicting theory, conflicting evidence, and bad pseudoscience. And I think we could all agree on that. The problem is we need a roadmap out of this. The politicians here kept being asked for a roadmap out of COVID. We need a roadmap to get out of this conflicting theory, this conflicting evidence, the use of bad science that underpins and drives our foot orthotic prescribing. And especially the conflicting evidence, which is the most important, I think is the most important part of that. And you get confronted with headlines This was just one of many, custom orthotics, no better than cheaper insoles for people with heel pain, a study suggests. And that was this systematic review and meta-analysis. I won't spend time. I mean, there are issues with this meta-analysis. Another one in the same journal found a slightly different result. The authors of that review had a letter to the editor on this review. I'm not going to get into those kinds of issues, but if you do a systematic review and meta-analysis of the literature on custom-made versus pre-made or custom-made foot orthoses for the use of heel pain, it's not unrealistic that these kinds of conclusions could be drawn. Conclusion, foot orthoses are not superior for improving pain and function compared with sham or other conservative treatments in plantar heel pain. Now, this was a very prominent journal, very prominent authors, and obviously the media, the bloggers, social media, they got hold of this. Orthotics are useless, was the conclusion. Now, the point of a systematic review and a meta-analysis, and they're so important again in this COVID era. You may or may not be following some of the hydroxychloroquine and ivermectin debates going on. The systematic, when there's conflicting evidence, you need your systematic reviews and your meta-analyses to critique, evaluate, and weight different studies and put all the data together to try and find your way through all this conflicting evidence. Now, before a study gets included in these reviews, they've got to meet certain criteria. The randomization has to be done properly. The assessments have to be blinded, all those kinds of criteria, which I'm sure you're familiar with. Now, when it comes to drug trials, let's think of, sorry, on my screen, my picture is covering my words. So let me just move it. Oh, there we go. Now think about an antihypertensive drug. And let's say a clinical trial was done testing a low dose of that particular hypertension drug. And that study showed it didn't work. So this drug works at higher doses, it doesn't work at lower doses, and the study showed it. Now, when it comes to doing a meta-analysis or a systematic review on that drug, that study will be included because it was good randomization, the assessments were blinded. So what that study will do, that will weight that meta-analysis and systematic review in the direction of that drug not being effective. It may well be, if we do a couple of other low dose studies of that drug, the conclusion of a systematic review might be this drug doesn't work because it included the low dose studies in that systematic review because they met the inclusion criteria. So should that drug not be used because it did not work in that trial at a low dose? And I'm sure you're seeing the point I'm trying to make. What about low doses of foot orthotics in clinical trials? Should they be included? How ethical would it be to include those studies on drugs or foot orthoses at a low dose into these systematic reviews? And this is one, I can recall this was close to 30 years ago, this one happened, and it was, reflecting on it now is really quite interesting. You may have heard of the McKenzie approach for low back pain. It's widely used within physiotherapy. Now, there was, again, something 30 years ago, a really quite well done study showed it didn't work. It was well randomized, assessments were blinded, et cetera, and it actually showed the McKenzie approach didn't work. And I can remember physiotherapy colleagues of mine at that time saying, well, it does work. It works in my hands. And I'm saying, well, yeah, but the evidence is it doesn't work. And it probably took me 20 years to realize what they were saying. The protocol for what was McKenzie's approach to low back pain used in the study was not what these clinicians were using in clinical practice. So this study was included in the earlier systematic reviews because it met all the criteria, and it biased the systematic reviews in the direction that it didn't work. Now, most recently, this is only a couple of years old, was this most recent meta-analysis that actually showed the McKenzie technique worked, because there's now enough studies showing it worked. That study that showed it didn't work has sort of been outweighed. The same issue with foot orthoses, that it's all about the dose. It was all about the dose of the McKenzie technique. It was all about the McKenzie technique matching what's done in clinical practice being done in the clinical trials. And another one, interesting one, is there's no doubt shockwave therapy for plantar heel pain is very effective, and we know that now, and it's widely used clinically. But if we go back and look at the literature in the early days, the studies that didn't have control groups, and we see this pattern all the time, that those studies with no control groups, and there's plenty of early studies on foot orthoses with no control groups, they're awesome. They work. The shockwave therapy for plantar heel pain, the results were really, really quite powerful, but they didn't have a control group. And when you put a control group in, you start controlling for placebo and other kinds of issues. When we look at the early studies that did have a control group, they were a bit mixed in their quality. Some were badly done, some were well done. One in particular, and it was actually done here in Melbourne, was very well done. As far as methodology goes, it was as good as it gets. But it didn't show that it showed that shockwave therapy just didn't work. And I remember clinicians who used shockwave therapy at that time screaming out, "Oh, this study has fatal flaws, it has to be thrown out." And I would look at the study and I couldn't see what was wrong with it. The randomization was fine, et cetera, et cetera. So if we look at the early systematic reviews and meta-analyses of that study of shockwave therapy, they generally concluded shockwave therapy doesn't work. Now, this particular study, why it was extremely well done, used a very low dose of shockwave, and clinicians were using it a lot at a higher dose. Now, subsequently, more randomized controlled trials have now been done. So the most recent systematic reviews and meta-analyses shows it does work. Enough positive studies now that negative study is outweighed. But should have that study have ever been included? Now, what I find interesting now is to think about the ethics of this. How many people have been denied the option of shockwave therapy because of that bias in the early meta-analysis systematic reviews, because of that one study that was done at a low dose? And I have a little bit of, that makes me a little uncomfortable to think that people weren't given that as an option for treatment because of the inclusion of a study that used shockwave at a low dose. How many people are being denied the option of foot orthoses because of a similar bias in the meta-analyses and systematic reviews? And I think that's an important issue. If we've got meta-analyses saying that custom-made devices are no different to shockwave, custom-made, and we've got studies showing that foot orthoses don't work, meta-analyses showing that foot orthoses don't work in plantar heel pain, how many people are not getting that as an option for their treatment because of those meta-analyses? The whole idea of a systematic review and a meta-analysis is that they're supposed to be free from bias. And I'd like to suggest that's not necessarily the case based on those examples. And I think if we're going to say, look at foot orthotic studies and include them in a meta-analysis, maybe an inclusion criteria should be the foot orthotics used in the study are of the type and protocol that would be commonly used in clinical practice by expert clinicians. Now, it may well be, because how often do you look at a study on foot orthoses and say, well, I don't do it that way, so this study doesn't apply to my clinical practice? Someone might present a study on using a root type orthoses, and someone in the audience says, but well, what about black type orthoses? You might have got a totally different result. They may not have. And I think all too often, I see foot orthotic studies that standardize the foot orthoses so much that what they end up using in the study, it's not like what anyone does in clinical practice. I've tongue-in-cheek actually suggested that anyone does foot orthotic research when they present their results at a conference, they should get up and say, this is how I did the orthoses, and then have a vote from the audience who does it this way. And if no one puts their hand up, they might as well sit down. The results are not going to be of any relevance to anyone in the audience. So this is where this whole concept of the dose of the foot orthotic to me, is becoming very, very important. Now, if we look at the studies that were included in this meta-analysis systematic review on heel pain, if we applied that criteria, were the orthotics used of the type that would be commonly used in clinical practice? The answer would, not many. Now, there might have been studies that used orthotics that I may not like, but I acknowledge that they are commonly done in clinical practice that way. I mean, I can live with that. So you've got to question the ethics of those reviews that includes these studies that have used foot orthoses at a low dose. How many people are now being denied the option of a potentially useful and helpful intervention because of that? So this is where I sort of want to say, how many studies on foot orthoses use foot orthoses in such a way that an expert clinician or thought leaders would use them in clinical practice? And I think this is where we start. You know, we need panels of experts or thought leaders to help researchers choose and design the foot orthoses that are used. Actually, just a few days ago, I came across another study. This was actually a lab-based study and looked at foot orthoses and function of the plantar fascia. And they actually showed that the foot orthoses did interfere with the function of the plantar aponeurosis. But what those researchers did is the orthotic they actually used, they deliberately exaggerated. Now, I've seen comments about, oh, this study is evidence we shouldn't use foot orthoses because it interferes with foot function. Well, a foot orthosis that's massively exaggerated interferes with foot function. You know, those foot orthotics were not what an expert clinician or a thought leader would use in clinical practice. So are the design features relevant to the pathology? And this is what we'll sort of touch on now. And were the foot orthotics of the right dose? And again, I'm sorry I'm focusing on research, but I've sort of come to the clinical implications of that, determining that dose. And a classic example would be these two foot orthotic designs here, which are somewhat extreme. You know, on the left we have, you know, the sort of the mesh device. I don't know how many are familiar with it, but it's a very high arch, you know, arch supporting, especially of the rear foot arch type device. And on the right, we have the sort of the Mozzie device, or that was, you know, massively sort of inverted on the medial side of the subtalar joint axis. Now, if I do a clinical study on one of these and I get a certain result, would I get the same result if I use the other one? And vice versa. Of how relevant is that to clinical practice, to do a study using one device versus using the other device? And of course, between those extremes, we might have got the Blake inverted type device. We have, you know, what about using a metatarsal dome? What about increasing the rigidity of the material? You know, so when you look at some of these research studies, you sort of look, well, did they use a different thickness of the plastic if body weight was higher? I mean, this is basic clinical practice. This is how we change the dose in our clinical practice. But almost always in a clinical study on foot orthoses, they might use 4 millimeters of polypropylene. Now, obviously, things have changed a bit now with 3D printing. And something as simple as, was a plantar fascial groove added if the plantar fascia was prominent? Now, if you think this for a moment, if someone has a very prominent plantar fascia and you use more of an arch supporting type foot orthoses in that clinical study, and maybe say a quarter of the people have a prominent plantar fascia, that orthotic's hypothetically going to fail. That orthotic is going to be uncomfortable. So that's going to, whereas if they'd put a groove into that 30% of the people that needed it, the results of the study may have been quite different. Now, we do this in clinical practice. I think that's one of the things I check for. And was there a first ray cutout if functional hallux limitus was present? We can debate whether functional hallux limitus really exists or not, but it is widely used in clinical practice. So in that study, if functional hallux limitus was present, did they do a first ray cutout or something else to facilitate that motion? If they didn't do it, then hypothetically, if a functional hallux limitus was present in a certain percent of people in the study, those orthotics are hypothetically going to fail. So I think you can see where I'm heading with this. What other design features were used to reduce the load in the pathological tissues? And this is this concept of pathology-specific prescribing. If that was not done, then how useful is that research to clinicians? Yet that study still will get included in the systematic reviews and meta-analyses. You know, at the end of the day, it's actually quite easy to bias a foot orthotic study. You just alter the dose. which is what we do clinically to get an outcome. And it's the same with drug trials. I mean, they will try and get the dose right first. Unfortunately, a lot of drug trials will give everyone in the study the same dose, whereas they probably should be adjusting the dose based on other medical parameters like body weight. So why don't we do the same in foot orthoses trials? And again, I struggle to see why this hasn't become a concept within foot orthotic study. And it's all about establishing the dose first. Skip over that. So let's look at a hypothetical plantar heel pain study. And let's say, for argument's sake, we're going to use these two foot orthotic designs, the MAS design versus the MOSI. The MAS standing for maximal arch subtalar supination, just a very strong arch supporting or rear foot part of the arch design, and the MOSI, the medial oblique subtalar inclination design, where it's sort of wedged on the medial side of the subtalar joint axis. Both reasonably commonly used in clinical practice, not necessarily in their extreme, but usually with other parameters as well. Now let's assume there was a no treatment control group. So we have three groups: the MAS, the MOSI, and the control group. And the study might conclude there was no difference between the MAS and the MOSI, but they were better than the control. Therefore, clinicians can use either device in plantar heel pain, but the effects were small. So if that's the conclusion of our hypothetical study, how has that helped us as clinicians? Well, it tells us there's no difference between those two devices. Now, we know clinically that they have two massive different effects, but in plantar heel pain, there was no difference. And don't forget, this is a hypothetical study. But the effects were small, so it weren't that much better than the control group. So what information does this give us in our clinical decision making? None. So what should have they done? And here's my hypothetical study. Whoops, I've just got to move my. Sorry, my video keeps covering up my slides. What should have they done? So let's take a group of people with plantar heel pain. Like in any study, you then do your baseline measurements and then you properly randomize them. We're going to randomize them to a control group or a placebo device. The control may be a prefabricated device, or it may be a soft insole, or it may be nothing. Then the group that gets randomized to foot orthoses, we're going to further assess them. Some will get a MAS device, those who have, say, clinical indications for a MAS type device, which I take as my clinical indication for a MAS type device is a lot of sagittal plane arch collapse. So they'll get a MAS device. Those with a more medial subtalar joint axis will get a MOSI type device. And then both groups, so you effectively have two groups, an orthotic group and a control group. The orthotic group gets variations in orthotic designs. Then we look at the outcome. Now, hypothetically, that orthotic group might do massively better than the control group. That could have been a prefab. So that, to me, is much more clinically relevant. That, again, hypothetical, to me, I would hypothetically or theoretically expect the outcome of that study to show foot orthotics are quite a lot better than a control placebo, rather than what we see now, where the effects are small. So what do you want to find? And this is sort of, like, again, we're talking hypothetically, the use of low dose foot orthotics, which might be the prefabricated, and the effects in that group might be low. The use of the high dose foot orthotics and the effect size in that group might be high. So, what might have happened? The MAS design. No, actually, let me just go back a bit. Let's just say this was the MAS versus MOSI design, not the orthotic versus control design. So, and our hypothetical study concluded there was no difference between the MAS and the MOSI type device. So what happened? The MAS design, it probably worked in some, especially those with a lot of sagittal plane arch collapse. It probably worked in those with moderate to low supination resistance. But it probably hurt others. Those with a medial subtalar joint axis probably gave up wearing their orthotics because they hurt. They were very uncomfortable. they probably stopped wearing them. But because of what's called intention to treat analysis in clinical trials, we still include them in the analysis. So overall, the mass design might have got a small X% improvement in symptoms. Now, the Mozzie design, it's probably going to work in some, especially probably going to work very well in those with a medial subtalar joint axis, high supination resistance. But it's probably going to hurt others. Now, someone who has low supination resistance and you give them a Mozzie device, you're probably going to sprain their ankle. They're probably going to stop wearing their orthotic. But because of intention to treat analysis, we keep their results in the study. So the Mozzie group might have had an overall small % improvement in symptoms. So at the end of the day, there was no difference between the two. So hopefully you can see how why a study comparing them might find no difference between the two. Whereas if we had used them in the one arm and prescribed them properly, we may have got a very, very different result. Now, please bear in mind, I'm oversimplifying this in 2 orthotic designs. I mean, there's obviously many, many others. There's variations of those. And here's another hypothetical plantar heel pain study. And these have been done. One group gets foot orthotics, and the other group might get shockwave therapy or NSAIDs or cortisone or stem cells or platelet-rich or homeopathy or a gluten-free diet or magnesium supplements or cannabis oils. Now, just as an aside, if you delve into some of the plantar fasciitis support groups on Facebook, you'd be surprised how often gluten-free diets, magnesium supplements are recommended for plantar heel pain. People swearing by them as helping. Now, if you use shockwave, NSAIDs, cortisone, homeopathy, or any one of those, X% are going to get better through natural history. If the other group had a low dose or a bad dose of foot orthoses, X% will get better just through natural history, but there'll be no difference between them. So whether orthotics are better than any one of these other interventions will depend on the dose of that foot orthotic given. And I think that's just what's really lacking. And I don't think a week goes by in which I don't see a study comparing foot orthotics to one of these other things. Most of them extremely badly done, and you'll probably never come across them because they're in such obscure sort of journals. So now, please don't get me wrong. Please, again, I'm oversimplifying things to try and give a view on it. Even if different doses of foot orthotics are used, the results may still be the same. Orthotics may not be effective in plantar heel pain overall. Orthotics may not be better than other interventions. It's just at this point we don't know. Now, we think we know clinically, but we just don't have that evidence because I don't think it's been done properly. Now, I am perhaps guilty of what's called the special pleading logical fallacy. Now, this is something that alternative health practitioners often use. There are plenty of studies showing a lot of the alternative health practices don't work. And then the people who use these alternative practice often say, but a randomized controlled trial is not the proper way to test the treatment that I use. So it's applying standards, principles, and or rules to other people or circumstances while making oneself or certain circumstances exempt from the same critical criteria. Now, am I being guilty of this? Am I trying to exempt foot orthoses from this to make excuses because I want them to work? And I think we've always got to be careful of our own biases. The whole idea of critical thinking is to be able to critique and understand your own thinking. And I think there probably is an element of that in my thinking, but dosing is applied to other things in medical research, different drug doses, different doses of shockwave therapy. Why should it not be applicable to foot orthoses? But am I just saying this to make an excuse for why foot orthotics are failing in clinical trials? Now, I just want to refer to this, it's a couple of years old now, Richard Jones's work, and this is, now, when it comes to lateral wedging for medial knee OA, the most recent evidence or the most recent systematic reviews and meta-analyses are showing that it probably doesn't work too well. There's certain question marks over it. But in this particular study, so effectively what happens is, for these kinds of research, you take a group of people, and I've done these studies with medial knee OA, you give half them a lateral wedge, and then you give the other half a placebo or a fake insole or something, and then you follow them through time and compare them. And you generally find between the two groups, there are no differences. But what these guys did was took the people who were randomized to the lateral wedge, and they did their 3D kinematics and kinetics. And those who got the lateral wedge, there were two types. There were those that biomechanically responded. So that knee adduction moment at the knee went down. But there were also those where that knee adduction moment did not go down. So within the orthotic group or the lateral wedge group, they had what were called biomechanical responders and non-responders. So when you compared the wedge group to the control group, lateral wedging didn't work. But when you compared the biomechanical responders to the control group, it worked. So this is a perfect example of exactly what I'm talking about. It's about getting the dose right. So it's about we might design a foot orthoses for a plantar fasciitis study. We will want that orthotic to make the people with plantar fasciitis biomechanical responders. So we'd incorporate design features so we know that they would respond biomechanically or kinetically or kinematically, and then compare those people to the control group, because we know from kinematic and kinetic studies that a number of people who get foot orthoses don't respond biomechanically. So this was probably the first study or most recent study that really looked at this whole concept of dosing, or in their terminology was the biomechanical responders and the non-responders. And again, this bottom study here, this was a 12-month study that I was involved in which we showed they didn't work, that there was no difference in the wedge group versus the control placebo group. But would have we got a very different result if we had only included the biomechanical responders in our results, or only permitted the biomechanical responders to come into the study? And I think that's the key point. And then it comes to this ethical point is, how many people are being denied lateral wedge insoles for medial knee OA now because of the systematic reviews and meta-analyses showing they don't work? So what does all this mean for clinical practice? So hopefully you get the point of dosing. Dosing is something we do every day in clinical practice. To me, it's about the clinical translation of research into clinical practice. Now, we could talk all day on what are the strategies that could be used to change the dose. Well, that's what we do our clinical tests for. That's why labs have a prescription form, for you to change the dose. Labs ask for the body weight so they can change the dose of orthoses. Or if you are prescribing the thickness of the plastic you want, you're going to ask for a thicker plastic in a heavier person. None of the clinical trials do that. Supination resistance, if that's higher, we're going to use a more rigid device. We're going to use a more inverted device. We're going to use a more Kirby-Skive Mozzie type device. If supination resistance is lower, we're going to use less of those design features. Again, this is this dosing principle. If the fascial cord is prominent, we're going to order a groove in that device, because the last thing we want is a high arch device pushing on that plantar fascia cord. We work out where the subtalar joint axis is to change the point of contact, or if we're going to use a Mozzie device or a medial skive device, how big a skive, where do we want that skive? So again, this is what we do. Hopefully with what I'm saying is you become more explicit in thinking about these in terms of altering the dose of the foot orthoses. So look, by way of conclusion, I've gone through it fairly quickly. It's all about, translating research into clinical practice has to be a priority. There's no doubt about that, but that research has to be translatable. Researchers have to use foot orthoses that are of the design and type that are commonly used in clinical practice. And when they present their research, they have to ask clinicians present at that conference, is this how you do it? It has to reflect clinical practice. I often talk about the experts and thought leaders. Some foot orthoses used in clinical studies I may personally not like, but I will acknowledge that what they're using is commonly used by a lot of people. So, I can live with that. And I think the important thing is, foot orthotic dosing, it is a thing. It is a concept. It's something that we've got to get our sort of head around to sort of make it more explicit, demand more of researchers, better understand our own clinical practice to change that dose. So I'm happy to pause there. I'm just checking the chat. No one's asked any questions yet. So look, I'm happy to hang around we've gone 40 minutes. I've got plenty of time this morning. I'm not going anywhere except for a run.
Okay, that's fantastic, Craig. Thank you so much. Yeah. The immediate thing, well, if anyone wants to ask any questions just on the platform there, you can ask through the question and answer section there. There's one message came in there from, okay, hang on, there's a couple of things.
There's a question here from Martin. I'm not sure I understand it.
Strategies to change the dose if a patient has functional hallux limitus plus 3 degrees bilateral abduction at toe off. Version A, brackets, the correct prescription of an orthotic will be prescribed, but what if the patient has functional hallux limitus with 30 degrees of bilateral abduction at toe off? In this instance, version A would be uncomfortable at, for example, the medial navicular. Is the degree of abduction generally overlooked in getting the dose right?
Yeah, look, I'm not sure what it means by 3 degrees abduction at toe off versus 30 degrees. Is that it's a terminology? I'm not sure what that means.
Yeah, probably use a different. Clarify in terms of how you're measuring that. I suppose what Martin's saying there is that if there's different variables in how someone assesses a patient and the measurement of a patient, then that's going to affect the dosage. And
okay.
I suppose that's, I suppose that
Martin's responded, it's just an abducted gait at toe off, so that's okay. That was
Charlie Chaplin.
Said, Charlie Chaplin, Look, unfortunately, and this is something that I don't often make explicit, orthotic prescribing is almost always one of compromises. You can come up with an ideal prescription for that person, but then, and this is how I often work backwards. I often work out exactly what I want to do, whatever, based on the parameters that are present. Then you start compromising on them. You compromise on them to fit in the shoe. One clinical test may say they need this, another clinical test may say they don't need that. So that's where just your own clinical experience and skills come in to make a compromise between those design features. So,
which I think touches on what you said about the researchers having to connect with the clinicians and what they're doing in clinics, and in some way translate that into, well, this is what expert opinions are doing. And of course that's complex and it's multivariate, which is also based on, well, where were you trained? Who was your influencer? What was the paradigm you adopted in terms of learning? So, it's interesting being the founder of a lab. We get all sorts of prescription dosing coming in, and sometimes we have to discuss it with the podiatrist in terms of manufacturing protocol. But I really appreciate you coming from the research university background, being able to tell us as clinicians, right, look, what you're doing clinically is potentially very relevant, but you need to influence the researchers as well. So it's fascinating. I was also really taken by your concept of design features. And I know that certainly in my clinical practice, I tend to look for, well, what's the diagnosis? And then why would that structure be overloaded? And then how do we offload it? And to think of foot orthoses as load modifiers. And they're only one part of the equation. So how else do we unload a particular structure? Is it footwear? Is it body weight? Is it, strength and conditioning? Is it mobility, flexibility? All of that. What about as people get older, they live longer, they lose muscle mass, they become weaker, you get, it becomes more complex, doesn't it? What about metabolic disease? What about other medical conditions? It all starts to affect how we create the prescription, which is the dosing.
Yeah, but you imagine trying to do that in a clinical trial.
Yeah, that's the challenge.
You know, and that's, I think that's the challenge that like I can recall one clinical trial that showed foot orthoses, so custom made, were really no different to prefab in outcomes. But part of the protocol in the custom made group is they did not do adjustments to the device if they were uncomfortable. Now, if we give someone a foot orthoses and they come back a month later and it's uncomfortable, we adjust it to make it comfortable to get the clinical outcome. So this clinical trial found there was no difference, but how's that? It's just not remotely close to being reflective of clinical practice.
Yeah, absolutely. Craig, there's another little question coming in from Judith.
I saw Judith's one, yeah.
Is it not better to give the minimum prescription possible? And then a little statement, which is, I've seen some very extreme orthoses.
Oh, of course, yeah. Like, yeah. At the end of the day, I often like to use plantar heel pain, plantar fasciitis as an example. To me, the purpose of a foot orthosis and plantar fasciitis is to reduce the load on the plantar fascia. So you add design features in your prescription to do it. Now, some of those design features do have some evidence from static-based studies, and that's, you know, lateral forefoot valgus posting, lateral wedging, plantar fascia groove. They have been shown to reduce the load in the plantar fascia, but for shoe fit reasons, you'd want to do the minimum possible to get a reduction in that load. So, I mean, I agree. I think you want to do the minimal dose to get the clinical results. And obviously, if that patient's not responding after a month or so, how you expect them to respond, you increase the dose. And that's exactly what general practitioners do with drugs. You know, why should we be any different? You know, they want you on the lowest dose.
I think that is so pertinent, because anyone that's in any type of clinical practice, that's what we're doing. We're modifying, we're tweaking, we're trying to get it right for the individual. N equals 1 to a certain extent, but how do you put that into a clinical trial and be randomized and meet all the criteria? That little comment here from, let me just get this. It's coming up on the chat. First up is great job as always, Craig, from Bruce Williams. And then
hey, Bruce.
Yeah, Bruce is on, but it's probably United States, I imagine.
Bruce, yeah.
Yeah, Martin Parry, thank you for the great session from Martin and Parry. Lovely to see you in sort of real life, virtually, Craig. Bruce has got a little comment here. You cannot expect a first-ray cutout to work alone in individuals with extreme external rotation. Using a digital wedge or Cluffy wedge under the great toe will aid the use of the first ray, compared to achieving the goal of keeping the first ray plantar flex for a longer period of time. I mean, this is the whole dosing concept, is that each of us brings something to the table as expert clinicians, and we've done something that works for us and we're going to keep doing it. Yeah, and you might get certain trains of thought that originate in the United States, some in South Africa, some in Canada, some in the United States, some in Ireland, some in the UK. Again, depending on your frame of reference, who taught you, what worked for you, what do you keep iterating to make something better? But how do you research it? That's the trick.
Well, I think it can be done, and there's a couple of questions coming up. I'll deal with that in a moment. But it's those international differences, or those inter-university differences, which are so important to account for when you're designing a clinical trial. Because if say the researchers were undergraduates at a certain university, if they teach at that university, and that university is a little bit different to the next university or the next country, if they do a clinical trial, the results are not going to be relevant outside of the people who use their foot orthoses that way. But to me, the way around that is that's where you get a committee of thought leaders, expert clinicians, you know, from around the world, not hundreds of people, but enough. And then so when you're designing your clinical trial, you say, okay, look, what should I take into account in the orthotic prescription in this trial, and try and get a consensus amongst that group, even though there might be some disagreement. So what they end up doing actually makes sense to a clinician. You know, well, okay, I do it that way. Oh, okay, they don't work. Oh, but they do work. And I think the thing is, we don't know. Look, Helen just asked a question about this biomechanical responders, and it's, again, if I use the example of plantar fasciitis or plantar fasciopathy, plantar heel pain, however you want to call it, you know, to me, the whole idea of the foot orthoses is to reduce the load on the plantar fascia. So you incorporate design features into that foot orthoses that you know will decrease the load in the plantar fascia. Like I said, we do have some studies. We do have a lot of thought experiments that tell us that. That's that lateral forefoot wedging, medial heel wedging. They tend to reduce the load in the plantar fascia. So we assume they would be the biomechanical responders. But if you just give everyone with plantar fasciopathy a modified root type device, how many of them are biomechanical responders? It could be possible quite a lot aren't. They don't respond. Then another classic one would be a posterior tibial tendon problem. That's where you need more of the medial wedging type design features, whether that's a Kirby Skive or a Mozzie, and you don't necessarily need much arch supporting design features. So again, if you're going to do a clinical trial on foot orthoses, do you go for the arch supporting designs or the medial wedging designs? Now, I know from my own clinical experience, medial wedging design and a post-tib problem works. It's one of those things that you really get quite confident it's going to work. So again, without 3D kinetics, you can't tell who the biomechanical responders are. Well, what we can do is use thought experiments, results of some studies to extrapolate to, well, if we do this to the foot orthoses, this might. Plantar pressures may be helpful in that area to help you determine the responders and non-responders. So again, it's about, we want the responders in our clinical trials. We want the responders in our clinical practice.
Okay, you mentioned something there, Craig, which I want to jump in on, is the 3D kinetics. If we look at the last decade and the movement of research to look at kinetics as being the key thing rather than kinematics, how do we get to the point of measuring or in some way quantifying the kinetics, which is the forces that are being loaded through the foot and various joints and so on? How and when do we get to that?
Well, the problem is we do not have the time, and patients do not have the money, generally, to do that. And that's there's more and more of these 3D systems going into clinical practice, and I think that's great, and we can do that.
But is this 3D kinematics or 3D kinetics? Because I'm thinking
unfortunately, a lot of the systems are using the 3D kinematics. Some are looking at the kinetics now using force plates. Some can extrapolate that from plantar pressure. The problem is, it's time and money. I don't see in the short to medium term future that's really an option for most people in clinical practice. There may be something coming in the future that will make that a lot easier, but it's all about when you're issuing an orthosis to someone, ideally you can measure the kinetics in some way, either via plantar pressures or via a 3D system that tells you I have a biomechanical responder here. Or if I don't have a biomechanical responder, can I modify those orthotics to make it one? And I'm just, I struggle with this one. And so to me, what we've got to do is we've got to, from the laboratory and university-based systems is do the research on this, but then come up with clinical tests that we can do simply in clinical practice that tell us, well, this person probably is going to be a biomechanical responder for this reason. And this may be something as simple as Jack's test. They standing flat in the ground, you dorsiflex the hallux, up comes the arch, you then put them on the orthotic and you do that again. Now, if that gets easier, we assume that they're perhaps a biomechanical responder because we've reduced the load in the plantar fascia. But we need the 3D kinetics research from the research labs to tell us that is the case. So to me, it's about what are simple clinical tests we can do when we issue the orthoses, rather than have access to these systems that at this stage are just not practical to do.
So as I understand that, then it would be great if we had research facilities that were looking at predictors that would indicate to us as clinicians when someone was going to be a biomechanical responder. Okay, wow, that would be.
I know Richard Price is. Yeah, but I know Richard Price and his group are doing that in medial neo-A. They've now worked out who the biomechanical responders are, and they're now looking at, well, how can we pick them clinically?
Well, if there's any researchers on this call, get on to this.
Okay.
I think
Great. Well, yeah. But that's, look, it could be something as someone with medial knee OA, get them to a squat. How painful is it? Put the lateral wedge under, do the squat again. If that immediate pain goes down with that squat, are they the ones we should be using? Are they the biomechanical responders that we can confidently use these people? Or if there's no change in the pain with that lateral wedge, well, maybe we don't waste our time going down that pathway. So again, it's while it'd be nice to have those clinical tests, it'd be even better. So it'd be nice to have the tools or the kinematics to assess that. We don't clinically, you just can't. It's not an option at this stage. So, but that's an example, and I think there's probably many more.
Okay, that's fascinating, because I mean, when let's say we get a patient that doesn't respond, let's call them the biomechanical unresponder. I mean, a lot of the time in clinical practice, now that I'm a bit longer in the tooth, Craig, I'm drafted in to deal with the complex supposed failures, and things like modifications to orthotics are certainly one aspect of adjusting the dose, but a lot of what we would be looking at, and I know this is happening clinically with so many pods, would be the strength and conditioning, would be footwear advice, would be flexibility, mobility, would be adding shockwave, so all these other modalities come into now potentially making that person a biomechanical responder. Yeah. Maybe placebo as well. You pay more attention to this person, they feel more, I'm going to get better here because somebody's taking care of me. It just gets so complex in terms of a research randomized trial to say it works or not,
Yeah, well, the other issue is that randomized controlled trials usually only test one thing, foot orthoses versus shockwave. But in clinical practice, even if you don't use foot orthoses, you use shockwave, you do rehab, you do exercises. And I don't often talk about the exercise, but of course I do it. I'm here to talk about foot orthoses, so I think people might get the impression that we don't do all these other things, because that's what clinical practice is. And maybe perhaps better clinical trials will test this protocol of therapy versus this one, as opposed to one
Craig,
tool versus another.
A little question came in here on the chat, and it's from Michael Plank, and he's asking, doesn't supination resistance give us some idea of kinetics in the foot? ?
Yes. Hang on, I better be careful. Yes, we assume it does. That if supination resistance is high, we assume
that's a good political answer.
Well, yeah, but I think it's
which is
supination resistance is high. We assume the forces driving the foot into that pronatory position are high. Therefore, we need high forces to counter it. So that's all kinetics. The data supporting that is, there is one study that perhaps suggests that being the case. Now, I don't think it's that difficult for someone to look at the kinetics, kinematics, and supination resistance to confirm that. So we just got to be careful. Yeah, but you're right, it does. And it probably will. But actually, I see a question. I see a question here from Christopher about a sham device for an RCT, and I actually, and I defer to Simon Spooner on this. He has had a lot to say on this, but I don't think you can, like, if you're going to do a study on foot orthoses and you want foot orthoses versus a control group or a placebo, I don't think you should actually be trying to do that, because you could have a placebo no treatment group, but if you do a sham device, it's still a device, even though
Correct.
Like I've seen, I mean, Carl Landolf, he did what was a very well designed study 20 years plus ago. The sham device he used was, he still took a plaster cast of the patient, so they still assumed they were getting a custom made device, but then he molded a very soft EVA to the shape of the cast and ground it down to look like an orthotic, but you can roll the device up in your hand. That was his sham device. But the problem is that it may have still had a mechanical effect. It may not have. Any
device may have affected the loading. It's hard to know.
So what I would rather see people do is, we're going to compare this orthotic design to this orthotic design. But orthotic design B, maybe that's so soft EVA, it probably doesn't have a mechanical effect. But I think to call it a sham or a placebo or a control device is probably wrong. It should be a device that has minimal or no effects, or even better, do the lab work and say, this is the effects of this orthotic B, this is the effects of this orthotic B in the lab, this is the clinical outcome we got. So it's about not calling them sham devices, it's about not calling them a placebo or a control.
But would it be better not to have a control group that has no intervention? Is that not better?
But the
I can
thing
see
is,
where you're going with this,
Like I think it was funny when we did our 12-month RCT on lateral wedging versus a placebo. I spent 12 months lying to the placebo group. I had to give the same spiel to both groups to not bias them. I had to make the wedge group believe they got the treatment. I had to make the placebo group believe they got the treatment. So to have a control group that gets nothing might be helpful if you have 2 or 3 treatment groups. You've always got to give them something. You've always got to, because you've got to make that group that got the so-called sham device believe they're being treated. And that helps you tease out how much of the effect of these are placebo. And that may be quite high. But I think, and again, going back to plantar fasciopathy, and this is, and I think Sever's disease is the classic example of this, that if you take, say, 100 people today who've got Sever's or calcaneal apophysitis or plantar fasciitis and come back in a week, 10% will be better. Doing nothing.
Yeah,
now, if you gave them all a useless treatment, a week later, 10% will be better. Now, you try and convince those 10% of people that treatment you gave them wasn't the reason they got better. You can't. So it's about teasing out that placebo effect, making them believe they're having the treatment.
Yeah, well, I think you're onto something with that, predicting the biomechanical responders. And there's a little question there, I don't know if you spotted there from Bruce that came up there, just the last one. And maybe we'll finish with this. We've been on for an hour, so I'm conscious of everyone's time. And Bruce is asking there, you mentioned in the lateral wedge knee osteoarthritis study that a lateral wedge worked when there was positive biomechanical response. Other than seeing if a patient's pain reduced with the use of an orthotic, how would you suggest that we determine the use of different orthotic modifications as to whether a positive biomechanical response occurred?
We don't know.
The vast pains.
Yeah, we can make assumptions, and hopefully with better predictability from clinical tests based on lab-based research. I think plantar pressure changes may be better quantifiable to predict that, but it really is difficult. And I think the lateral wedging with a knee OA is a classic one, because someone's got pain with medial knee OA, you put a lateral wedge in and they're a biomechanical responder, their pain may not get better. But if you hadn't done that, their pain would have got a hell of a lot worse because knee OA progresses. So, there's all those kinds of challenges, all those kinds of things to tease out. And I actually think what I might finish on is I'm actually writing a blog post at the moment, and I've got as far as the title. It's a challenge. And I've always said mechanical problems need mechanical solutions. And by that, I mean, we need a mechanical solution to reduce the load in medial knee OA and the plantar fascia or something like that. I don't think that's the case anymore. I think myself in the last 2, 3, 4 years, we've learned so much more about the psychological, the response to placebos, how much of the use of language, words matter, all that kind of stuff. So I've got to eat my words. Mechanical treatments don't need mechanical therapies. And maybe, Martin, you might want to get someone else on who knows a hell of a lot more about that than me for a future webinar, that it's not all mechanical.
Yeah, absolutely. Yeah. Mm-hmm. And I remember back in the day, some people saying to me, maybe the more successful practitioner is the person that's more believable, and how you develop empathy and you communicate with your patient. I think it's definitely part of it. So the jury is still out here then. There's a lot more work to be done, Craig. This is the problem with our profession and orthotic therapy and MSK treatments. But listen, thank you so much. And there's a comment come in there, someone saying that this has been very interesting and very thought-provoking. And I think that's the key thing. That's what we're trying to do here, is to get people to think a little bit differently. And you talked about this at the start, which was the critical thinking. And I think that is one of the key things I take away from it, is the critical thinking that's needed in our clinical practice. So thank you so much for joining us from Australia this morning.
It's been a pleasure. I always like doing these because I like doing these because it makes me think about it as well.
Which is great. And thanks to all the people that came on and give up their time to join in. And thanks for the questions. So everybody, wherever you are, be safe, have a good time, and take care. And we'll see you again at the next webinar. So thanks. Great.